Welcome to the Ultimate Dentist podcast. Join us to hear success stories of various individuals and learn clinical and life hacks to help you become the ultimate dentist. Hello and welcome again. I hope you all are doing great. In this second part of the few parts series of step-by-step protocol for full mouth reconstruction, we are going to discuss about mock-ups. This is a very important part of the stage, but let's recap what we discussed in last episode. In last episode, we discussed that appointment number 1 and appointment number 2 will consist of your initial assessment, your comprehensive assessment, proposal of treatment plan, and record gathering. So you're going to take some records. And this is all part of our overall 3-step technique to full mouth reconstruction. And appointment number 1 and 2 is part of step 1, which is treatment planning. Today, we are going to discuss about appointment number 3 and appointment number 4. Again, that is also part of part 1 or step 1 of 3-step technique. We also discussed some of the key factors in affecting your treatment planning in last episode. Those factors were assessing patient, whether you can get on with the patient or not, load testing, whether TMJ is in a healthy position or not, checking wear, whether the patient has generalized wear or localized wear, and how to treat that wear. Because if patient has a dentoalveolar compensation, you may need to think about orthodontic treatment rather than raising OVD sometime because of the aesthetic implications of just raising OVD. We also discussed about 𝗙𝗪𝗪𝗀, and this is very important for me whenever I am planning any treatment. I want 𝗙𝗪𝗪𝗪 to be as flat as possible because we do not want the curvature or the incline or the anterior protrusive guidance to be very, very steep, because that can lead to a lot of issues. And we also discussed about limiting factors such as newly fitted crowns, crown with post and cores, implant crowding, or supra-erupted teeth. Now, once you have gathered data, mounted models, assess the mounted models, and this is where many dentists tell me that they don't have articulator or they don't know how to mount models. Of course, in my opinion, it is very important that you understand how to mount model. But when you are starting and if you don't know how to mount models, then at least you need to understand how to assess mounted models. Because yes, mounting models digitally is a way around of not being able to mount models properly. You can mount models digitally, but even then, you need to be able to assess those mounted models, either analog or in a digital way. And that's where you need to make sure that you have assessed the model. You have then, so if you don't have articulator, what I would suggest is you ask technician to send mounted models on an articulator back. Many times I see when technician will send you your models back for wax subs, you will only get models, not articulators. Now, models without articulator, even though they are articulated models, they are useless because you cannot assess them. So the fact that technician has mounted models and did the wax up, you'll have to take their word for it. You cannot assess properly whether the guidance is the way you wanted or the OVD is increased the way you wanted. So make sure that once you have sent patients all the records, FMR and interocclusal records, you ask technician to send the models back, the mounted models back. Ask them to send it back with FMR and interocclusal records. FMR you can't really check, but you could possibly put interocclusal records back and make sure that the mounting is correct as much as you can check. But the other single important thing you need to assess is how the mounted models meet together, and this is the time you'll really be able to assess patient's occlusion in CO, how much vertical height you want, and how does the 𝗙𝗪𝗪𝗀 look like, and how much OVD you probably would want to raise. What I tend to do if I am not doing wax up by myself, I tend to do all my wax up for direct restoration by myself But for indirect restoration, I want my technician to do the wax up. Reason being that every technician has a unique perception of shape of teeth, and I want to know how they visualize the shape of the teeth. If the technician cannot do good wax up, in my opinion, they may not understand how the shapes work, and they may not be able to give you the good final result. So, and for me, shapes matter more than color. So you need to make sure you have the shape corrected. Now, once the technician has sent the models back, you need to, I tend to assess the occlusion and see and mark how much OVD I want to raise. I will increase or decrease the pin the way I want it and set the OVD according to that. And once I've set it, I'll mark it, and I'll tell technician to then do the wax up at that OVD. So you have set the OVD. Now, sometimes you don't know how much OVD you want to raise. What you can do is, when you are doing your records, you can build using, composite mock-up in patient's mouth. Just build a couple of central and upper end central and laterals freehand to increase the height, to see how much height you want of the teeth. You could increase the OVD if you want, but generally it's the anterior teeth and the smile and the height. And then that gives technician some idea as to how much height is good. And you can tell technician, okay, increase the incisal length by this many millimeter. Generally, when I'm increasing OVD, I am looking at my restorative space. Almost always I look at the anterior teeth, because you can open the pin up, and if the anterior teeth is way apart, then I can't build very, very thick platform to make them meet. So that will limit how much opening I can do. And that's why I like deep bite cases, because when you have a deep bite cases, you can open a lot and you can gain a lot of restorative space, especially in indirect cases, without having much issue. But if patient has a shallow anterior bite, and if you start opening their occlusion, you might get into trouble, because you won't be able to open too much without teeth looking very bulbous or bulky. So that's what I'm checking when I am assessing how much OVD I want to increase. So I will set the articulator according to the way I want. In this appointment, I also do a very important thing, which many dentists ask me, that, how do you guide your technician as to what wax up you want? Because if you just at this stage send the articulator back and tell your technician that do the wax up, they will give you the most beautiful wax up possibly you can imagine. However, they'll put wax wherever they need to make the wax up look beautiful. The problem with that is that, let's say you have not planned for anterior buccal veneers, you've just planned for functional reconstruction, where you're just going to have palatal backing and the incisal increase of the length, but not buccal veneer. But if the technician has put wax on the buccal aspect, and now that you can use that wax for mock-up, then you are giving patient a false impression as to how their teeth will look like. So in order to avoid this confusion, you need to write technician a letter explaining your treatment plan, explaining what are you planning to do. But that's not enough, because in my experience, many times technician can get carried away to make their job look very pretty, and they still end up putting wax wherever they want. So I tend to then mark the surfaces I want technician to put the wax on in pencil. And technician, you need to tell technician you do not cover any other surfaces, and make sure you create that very defined boundary as to where the wax needs to stop. And if this doesn't look aesthetically nice, then at least you can tell patient that, look, you need a buccal veneers to make it look nice, and then you can charge patient appropriately. So just make sure you guide technician in order to do the wax up. So let's say you have told technician to do the wax up, and technicians done the wax up, and now you've got the waxed up models back. Appointment 3 will be mock-up. Mock-up means a trial of the wax up in patient's mouth. And make sure that before patient arrives, you assess the wax up. At this appointment as well, I'll ask technician to send the articulated models. So send the models and articulators together so you can assess the wax up before patient arrives. I make wax putty indices myself, so I would wet the model. So make sure you wet the model. So you put some water on it so that it soaks up the water, because sometimes if you put putty, you're trying to make putty indices on the wax up, and sometimes putty can just pull the wax up out, or putty can stick to the model. So make sure you wet the model and then use putty indices to create your index. Now, sometime if you want more finer detail, then you can, once you created that putty index, you can flow some light body material and put the index back again on the model and really press it hard so that it captures every single little detail. Again, this means that your models which you take impressions on needs to be very super accurate. If they're not accurate, then what you will see is when you're doing mock-up in patient's mouth, you see a lot of excess material, which you need to then clean up. Now, once you made that indices, you cut the indices up to the cervical margin, so you only have teeth covered, not beyond cervical margin, not onto the gum, and that helps in removing your excess material. I use 𝗙𝗂𝗹𝗹 or 𝗙𝗂𝗋𝗹 as a temporary crown and bridge material to put that into the putty indices whenever I am doing mock-up. Before you seat putty indices, make sure you use PTFE tape, long PTFE tape in interdental areas. And what that will do is that will avoid your mock-up flowing into interdental areas, and will make sure that the patient can use TP brushes through this mock-up, because you are going to leave this mock-up for at least a week in patient's mouth to assess for various things. So you want to make sure that the interdental areas are clean, free. It's free of any material. So at least for anterior teeth, because that's where interproximal area is a bit more wider, you're going to put PTFE tape, just roll it out and put it in like a floss, and then put the putty index on top and pull those PTFE tapes out while your acrylic is setting, and that will create a gap. If there is very obvious undercut which you think your temporary crown and bridge material can get stuck into and might be difficult to take it out, then you need to just put some sort of a temporary material or blocking material or glass ionomer cement or something, just to block out that undercut. But use something temporary which can be easily taken out before you put that putty index back, because sometime when you are using this method, that your acrylic can flow into these areas where there is undercuts, and it can be a nightmare to take it out. There is no reason why you can't use a small round burr and a fast handpiece to drill your acrylic out, but it can be stressful or it can cause damage to the teeth. So you need to make sure that you block all the undercuts. Once that's done, you are going to assess aesthetics, phonetics, shade, and occlusion. Now, many times shade is something you can be forgiven upon, because many times the acrylic doesn't look as good as your porcelain if you're going to do porcelain restorations. But you need to make sure that the aesthetics and phonetics are appropriate. Many times patient may not be able to speak properly on the appointment, and that's why we are leaving patient with this mock-up to go home and try it out for a week before they come back. More importantly, you're going to check occlusion of patient. Now, if you're going to check ICP contact points and you're going to check guidance. Now, if the guidance and ICP contact points are way off than your mounting, then you need to decide whether your mounting is correct or it's wrong. Now, if the mounting is correct, but the contact points are not matching, that means when you're doing this mock-up, you might have moved your indices, you're not taking the indices properly, and the mock-up didn't seat, or the indices didn't seat properly in the mouth, and that's why there's a discrepancy. If your mounting is wrong, that could be a number of things. It could be your model, maybe your impressions wrong, or your interocclusal records were wrong, your Facebook records were wrong, or the technician didn't mount the model properly. There's multiple things can go wrong. So what do you do? I would suggest if the issue is, the discrepancy is very minor, then I would adjust it in patient's mouth and make sure patient's comfortable. If that adjustment is very minor, then I won't really bother about it. I would leave the patient with that, and I would accept that mounting and wax up, and I would accept that, okay, because I'm doing a composite build-ups, I can adjust the composite a little bit. It's not a big deal. If you really want to be certain on the day, and if you want to use something called stamp technique, or you want to use a technique where you're doing injectable composites, then what you can do is you can adjust the occlusion, and then you retake the impression of your newly adjusted occlusion to make you a study models, and you can use that for indices. Now, if once you've done the mock-up, and you make sure that you clear the interproximal spaces. Now, sometimes PTFE tape may not be enough to clear those interproximal spaces. You might have to use number 12 blade to just remove the flick out those excess material. And once you've done that, then you can leave the patient with mock-up in situ for at least 1 week. If patient wants for 2 weeks, you can leave it for 2 weeks, but 1 week usually is enough. And then you review patient in 1 week time. And that will be your appointment 4. Your appointment 4 will be your review appointment, or which is a mock-up after review of the mock-up after 1 to 2 weeks. When you're reviewing patient in appointment 4, you are going to check, you're going to assess mock-up or for any chipping. You're going to assess patient's TMJ and any muscle pain, because if patient's been wearing for a week and if patient's having muscle pain, then you have a couple of options. You can leave patient for a bit longer to see if the pain is just because something new, or you check occlusion, make sure there is no interferences, and leave patient for a bit longer. Now, if patient gets used to after another week, then no issues. If patient's still not getting used to that, then you need to really go back to the drawing board. You need to change the OVD. You need to either give patient Michigan splint, or you need to go back to drawing board and make sure that the pain is disappeared, and then you retry that wax up. Sometimes that means that you need to give patient Michigan splint and let them relax. In my experience of doing hundreds of cases, I have never come across at this stage that patient would have pain. Usually patient would have pain in the very beginning of the stages, and if you've done your job properly, then you would have sorted those patients out who may have get TMJ pain or muscle pain beforehand, and given patient more sort of a Michigan splint or some sort of a deprogrammer. However, I have had some students who have had patients who had issues with TMJ and muscle pain after mock-up. And I would always say that that's great, because mock-up is your testing time. You're testing everything without doing anything to patient's teeth. And this is the time, appointment number 4 is the time when you can really pull out of your treatment plan and gather your data again and regroup and go back to patient and say, look, whatever we are planning to do is probably not going to work, because I've done the assessment. This is what I've found, and your TMJ or your muscles are not really taking this increase in OVD nicely, and they're being sore. So you need to go back to drawing board, and you need to make sure that the muscles are, there's no issues with them, muscles or TMJ. Now, why this is important? This is important because it avoids you doing anything irreversible in patient's mouth. The way I was trained when I did my master's is we gave all our patients who needed full mouth reconstruction a Michigan splint before we started. And that was the norm. And because of that, it's a foolproof sort of a treatment modality, which means if you give patient Michigan splint, then you know whether patient's got problem with TMJ, any issues, patients are deprogrammed really nicely, and you start doing that. However, that will delay your treatment at least 3 months. And in practical world, it doesn't work all the time, delaying your treatment, because many times patient wants things there and then. But you still need to do your risk assessment. And that's why you have incorporated these stages, which will allow you to do things in a practical terms, but still doing your risk assessment. Okay, because one of the majority of the concerns dentists have is, what if I increase OVD and patient had developed TMJ problem? Now you're testing it out in this mock-up, and this is reversible. So you're also going to see any chipping or breaking of the mock-up. If patient's chipping or breaking, you need to see why. Is it because the mock-up's thin, or is it because the patient's bruxist and they're just destroying everything? And you need to warn patient if that's happening. Then you remove this mock-up. Once you assessed everything, you're happy with it, you remove a mock-up using either sickle scaler, hand scaler, usually works. However, sometime you need to have a fast handpiece if the mock-up is very thick, to just make a small section and then just flick them off to make them thin, and then flick them off. You need to warn patient that they will feel pull or tug when you are removing that, because it's not really a pleasant process. Once you've remove the mock-up, make sure that you have the tooth surfaces are cleaned, and floss individual interproximal areas, and make sure there is no remnants have been left. Then you would book next appointment for build-ups, either 2 weeks later or later than that, to allow gingiva to be sort of healthy, because many times, despite of you giving patient instruction, it's very difficult to clean in between, and the gingiva might be a bit sore, or they might be sore from you pulling and taking the mock-up out. So I would not advise you to book your appointment number 5 or your build-up appointments on the same day. So make sure your removal or review of the mock-up is a separate appointment, which is appointment number 4. Make sure you remove all the mock-up and wait for 2 weeks for gum to heal before you build the rest of the teeth. And so book patient accordingly 2 weeks later on. Now, this is your mock-up stage. And the mock-up stage is really important, because this will allow you and patient, both of you, to know that you both are on the same page or not. And it will allow patient to know that what they're paying for. So I generally break down my treatment into 2 phases, where I would charge patient up to mock-up, and I would say this is an assessment phase. After we've done all this, if I or you both do not agree on the results you're going to get, then we can stop. I would not have done anything irreversible to your mouth. Most of the time, because when we're increasing OVD, it's an additive wax-up. Unless there's a reductive wax-up, then you can't really do anything. But most of the time, it's an additive wax-up. And so that patients are aware that they need to invest a certain amount of money for you to do the assessment. The mock-up is also part of an assessment. So I tell patients that this is part of assessment. And after I've assessed everything, I can tell you whether you can have this treatment or not. But assessment fees are this much, which are non-refundable. And, because obviously it takes time for me to do the assessment. But majority of the time, I tell patients that, look, this is what I think is going to progress to because of my experience. But we need to still do assessments just so that we don't get caught out. Once you've done appointment 4, and before you move on to appointment 5, you may want to look into different things. So you need to look into stabilization phase. Remember when initially we were taught as stabilization, emergency phase, and stabilization phase, disease control phase, definitive phase, and then you have maintenance phase. So after you have done appointment number 4 and you know that this is your plan, you may want to do stabilization or disease control phase, where you need to do extraction of the teeth which need extraction, periodontal treatment, endodontic treatment, core investigation, where you're going to remove all the amalgam out, caries out, and do core investigation and assess the patient's teeth, and control any cause of the disease. Now, ideally, this all needs to be done at your appointment number 1 stage, in the sense that you've done appointment number 1, you need to tell patient that, look, before we go ahead with full mouth reconstruction, you need extraction, periodontal treatment, endodontic treatment, remove of the caries, and core stabilization, and control of the diseases. And then you move on to appointment number 2, which is record keeping, and then 3 and 4. But for some reason, if you have not done any of these, then you need to do it before you start doing any build-up. So make sure you have endo, perio, and caries, everything sorted. And then only then you can move on to your next step. Make sure you given patient that diet chart with patient, need to fill, so that you know what patient are eating or using. Make sure that you have a stable teeth with good endodontic treatment. Make sure you've done your core assessment, so you know that none of the teeth are going to flare out during, so the caries is not into the pulp, and you may not need root canal treatment. Once you've done the core assess investigation, which means removal of the old amalgam, you will also know whether that tooth needs an indirect restoration or it's a direct restoration. And this is how you will be able to tell patient as well that, after your appointment 4, when you're going to finalize the treatment plan, you will then tell patient that, this tooth needs full mouth, full coverage, onlay or, crown or whatever. So it'll help you in planning your case better. So in this episode, we discussed about mock-up, very, very important step of the procedure. So make sure you do not skip this, because it will help you in risk assessing patient and patient's needs and patient's TMJ and muscles. So in the next episode, we are going to now discuss about appointment 5 and further, which is your build-up appointments. So I hope you enjoyed this episode, and looking forward to meeting you in the next episode.